I'm broadcasting from a different location today, as in a different couch. I think this is my dog Cannoli. And I am looking for the information regarding this case for today. Um, Okay, so more people are joining. Today's case is an older case. I hope people can hear me. I don't have my typical Jessica Hokamp in the room, I don't think, to tell me that I'm audible. Okay, good. Um, so it's an older case that had was biopsied by Friendship in 2024 and has been managed for a couple of years to try to improve the clinical symptomology, and they've kind of had some frustrations with the results, and so we thought it would be a good kind of springboard for us to discuss diagnostics that can be performed in human nephropathology, and then also some of the more directed therapies that can be used in human nephropathology and compare it to veterinary pathology. So, uh, I see Dr. Skinner is on. Is JD there as well, Steph?
I'm actually at home for the
Oh.
next 4 weeks studying.
Yes. Are you both taking boards?
Yes, but only
Yeah.
one of us is taking time to study.
Oh, I can see. Okay, that's interesting. So I am actually looking at some of the SDS pages that have been sent from this case, and also trying to figure out the follow-up information that has been happening with that. Here it is. I finally got the folder with everything associated with it. But you're gonna present the clinical data stuff?
Yeah, I just put a couple of slides together with an
Perfect.
overview.
Okay. Then I will let you start with that, and then we will have some images to go over when we talk about the biopsy part.
All right. Are you guys seeing the
Yep.
very cute Frenchie? Perfect.
Is that really her?
That is really her. This is from her visit a month ago. So Millie is, oh gosh, probably at the time of her biopsy was like a 5-ish-year-old female spayed Frenchie that had presented to the RDVM for a single episode of vomiting and not finishing dinner, which was highly unusual for her. The RDVM found that she was azotemic, proteinuric, 4+ protein, ended up sending her to us. I don't have a great memory of exactly what happened while she was in hospital because it's been a year and a half and she was initially managed by one of our specialty interns. But she did have some somewhat significant changes on her ultrasound. They actually called her kidneys normal, but she had quite a lot of peritoneal effusion. She had some pretty significant lymphangioectasia. And I think they ended up saying maybe some like pancreatic edema as well. Because of the significant proteinuria, we did get biopsies when she presented to us, and then these are her presenting labs. So she's actually not that affected. This was 220 was when she presented, and then I think 222 is when we actually got the biopsies. And she was mildly azotemic. She was hypoalbuminemic and pretty significantly proteinuric. We had her on dexamethasone while she was in hospital, and we ended up sending her on home on prednisone and got the biopsies. And then I don't know if you want me to I've got all of her follow-up labs and stuff too, if you want me to present those now. So for the last year and a half, she has mostly done the follow-up with her RDVM and has only seen me a couple of times, but we were pretty suspicious that she had both GI as well as a kidney component to her disease. And as we were kind of trying to get her meds under control, she lost actually a pretty significant amount of weight. Her UPCs were kind of all over the place. We were pretty happy when we got the UPC of 0.31, and then on the next visit 2 months later, it was up to 21. You'll notice the CBCs come in here because we actually started adding in alkylating agents not that long ago. And I would say clinically, right around the time when her weight started to improve, she also clinically she was eating better, she was putting on weight. Her energy was pretty much back to normal, but her kind of degree of proteinuria has been all over the place. And we've gotten a couple of SDS pages in here. And then just as her medication list, so we started with steroids, we added in mycophenolate. It didn't seem like she tolerated that. We tried cyclosporin, once a day dosing, and then we moved up to twice a day dosing. We switched her to cyclophosphamide at Q3 weeks, and then I switched to a daily dosing. And that's about where we're at right now, is a dog. And I would say and you can see a little bit, she is starting to lose weight again. The owners say that her appetite's not great. Obviously her UPC at her most recent visit isn't the worst, but what's been somewhat difficult to manage and control is the complete kind of absence of changes on her SDS pages. And that's kind of it. So that's all I got.
Thank you for that. Okay. So, we had her at 3.5 whenever she was biopsied. So I think and according to our record, she's probably 5 now. But if we need to correct that.
That sounds right. Okay. Whatever I put there.
Okay.
That's fine.
And so this biopsy came in February of 2024. So the slides are no longer the scan slides are no longer available on the server. So we just have the images that I'm going to show you for a moment. That does kind of remind me that Dr. Nabity is on here as well. I know that you guys we do archive all of the scanned slides, but I'm just not sure how often they're getting put into the case folder. But this one should have already probably been now moved to an external hard drive, and then it has to go back up to the cloud to be saved for archival purposes. So we'll need to make sure we get all that information. So, but I do have photographs of the lesions, which I will share with you as let's see if I can do that this way. And so it was a good biopsy. They almost always are when they come from Friendship. And the main focus that we examine, obviously, for proteinuric patients is focusing on the glomeruli, and pretty much uh, all of the glomeruli resembled this type of appearance, which is characterized by a lot of nuclei all within the glomerulus, and so there are too many cells here. I think even one is undergoing mitosis here. This might be a mesangial cell or maybe an endothelial cell, but we do have a mitotic figure in there. And the H&E is a difficult slide for gauging where the increased cellularity is occurring. So we often like to do other stains for that. Here is another H&E on uh, again, showing a lot of nuclei. They're all closely crowded. And our third H&E from this case, again, crowded nuclei. There's right here in the middle, there is a right, kind of, you guys can see the arrow, correct? Just making sure. Yes.
Yep, we can
I'm
see it.
assuming you can see the arrow. Okay, that's a little apoptotic cells, a little bit of nuclear debris in that region of the glomerulus. Um, that we're going to go to the PASs next because that helps us localize where that increased cellularity is occurring. And so the PAS outlines the glomerular capillary loops. And you can see that within this particular glomerular capillary, we have 5 nuclei, and that is above our cutoff of 1, maybe 2 nuclei that is allowed to exist in a capillary, in a glomerular capillary. So there is evidence of endocapillary hypercellularity, as well as evidence of inflammation within the mesangial zones as well. So more of the base of the glomeruli, the tree trunk of the glomerulus also has too many nuclei. Um, and uh, the other PASs are going to show us the same feature where if you can actually identify where your glomerular basement membrane is, and then count how many nuclei are each in that capillary loop. In this particular one, we have 4 nuclei. Again, it's above our cutoff. And it's a global appearance. It's in pretty much every single glomerular capillary loop that we have increased numbers of nuclei. And our last PS is here. Again, here's our little nuclear debris from our cell that's undergoing apoptosis or necrosis. We have a little bit of nuclear dusting as well over here in this one particular region of this capillary loop. This has the classic mantra, or I guess maybe this is a good example of when you're looking at a glomerulus and you really can't figure out, am I looking at a capillary loop? Am I looking at mesangium? Where in the glomerulus am I looking? It's just all like it's all jumbled together. When that happens, the that is evidence of a proliferative process. And so it's usually seen in membranoproliferative glomerulonephritis. So um, the the confusion when you're looking at a glomerulus, the cellular does show you that there's hypercellularity both within the mesangial zones and in the capillary lumens. Um, the trichrome is next. And so again, we're looking at that same glomerulus we saw first. The red cells are now popping out, being bright red. The other cells are, the nuclei are still kind of that pale blue. This particular glomerulus is extending out into where the proximal tubule is bulging off of the Bowman's capsule. And so there's a little bit of plasma that's being pushed in there as well. So it's a little more almost like, think about it almost like an explosion of material on that capillary loop that's going up towards the urinary pole. Um, the the glomerular basement membranes themselves are not strikingly thick. Um, the comparison that we are allowed to use as our acceptable thickness for a GBM. I'm going to come back to this particular glomerulus in a moment, but the acceptable thickness for a GBM should be about the same thickness of the tubular basement membranes of healthy tubules. So this is a healthy tubule, this is a healthy tubule. And if you look at that blue line, that is your tubular basement membrane. If your GBM is thicker than that, then it's over, it's too thick. That being said, this isn't strikingly thick. There are plenty of examples that we could show you where it's 3 times the thickness of a normal tubular basement membrane. And this one looks probably the same thickness, maybe slightly thicker. There are some kind of red material along the surface or along this capillary lumen here. It's a little more prominent in our previous glomerulus. These dots all along here and dots here. I think if I can make it a little bit bigger, let's see if I can get it. I'm not, it's just going to do a weird thing with the screen, but the red kind of dot material all along that capillary wall gives us the hint that there's immune deposits there. On the trichrome stain, immune deposits will be red. And you're not going to be able to catch them with the H&E because immune deposits and the glomerular basement membrane are both the same color pink. So an H&E is not going to show you immune deposits. The PAS uncommonly will give you the hint that they're immune deposits, but they don't. It's not because of a tinctorial change, tinctorial stain. The PAS and the Jones are going to be very similar in the hints that they're going to give you about deposits. So if we go back to the Jones, both the PAS and the Jones stain are very good for identifying the location of the glomerular basement membrane. The Jones stain shows a GBM as being a dark black line, and the PAS shows the GBM as being a pink line. And now it's not always very strikingly clear as to where the GBM is and other places, but you can see that every so often when you're catching it, you're able to see a pink line. And so the Jones will do the same thing where it's going to show a black line. And both the PAS and the Jones stain can help you assume or predict that there will be deposits based on the type of remodeling that might happen in the glomerular basement membrane. So those of you who have attended these rounds frequently are aware that we can see spikes or we can see holes with the Jones stain. You can sometimes pick it up with a PAS as well. The Jones is the best. And let me take that back. The EM is the best. Jones is a poor man's EM, and then PAS is a poor man's Jones, which is a poor man's EM. So that being said, in all of these pictures, there's not striking GBM remodeling. You can identify the capillary walls with this Jones stain, but it's not the striking type of capillary wall remodeling that we see with a chronic, long-lasting membranous. So the histologic diagnosis was consistent with at least a proliferative pattern of glomerulonephritis. Based on the trichrome, I was pretty sure even early on that there was going to be some degree of immune complex deposition because of those red dots on that trichrome. So we were pretty sure we were going to have an immune complex deposition. And so then the next available study we were able to get was immunofluorescence. And so let's see what they look like. And this is just kind of haphazardly arranged as how we had the images, but the C3 staining shows that there is granular staining for the glomeruli, the entire glomerular tuft, so it's global, and it's probably a 1 to 2 staining, so the complement system has been activated. There's really not much IgA there. The IgG is pretty good for our typical IgG staining. So the staining process or the staining quality needs to be granular because each one of those granules represents an immune complex. And so it's outlining these capillaries. It's also slightly present within the mesangial zones as well, but each one of these capillaries that's outlined has a little dot, 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 and each one of those represents an immune complex. So the IgG was positive. IgM, we always see IgM positivity, even in normal dogs. It's always like a little smudgy. Sometimes it's splotchy. We still stain for it. It's probably just more serum that's being collected or being pushed into the mesangium. Sometimes IgM can be very, very strong in segmental sclerosis cases, but it's the pattern that makes the difference. And so this one looks like it's kind of blush or hazy. It's not making a good granular complex. And the lambda should be strong as well. And look at how gorgeous that lambda is. So again, each one of these little dots represents an immune complex. I'm going to try it. Let's see if I can get it. Oh, no, it's going to do that thing again. Okay. Um, so, uh,
Rachel,
yes.
I have a question.
Mhm.
So, have you noticed any potential differences with the different types of immune complexes and what pattern shows up? Not necessarily like membranous versus membranoproliferative, but does just seeing how like prominent the endocapillary hypercellularity was with the how prominent the endothelial cells were versus having more neutrophils attracted. You get what I'm trying to ask?
For
Like, for immune complexes, is there one that might trigger more of a neutrophilic response, I guess, versus one that just annoys the endothelial cells more?
Okay, I can see what you're saying. If there are true immune complexes that are proven with electron microscopy, um, it's still going to be a granular pattern. We have had rare cases where the C3, so it's more of a complement driven process and not necessarily as strong for the the immunoglobulins. And those are probably kind of more similar to what we think about in humans with C3GN. And they can have pretty good hypercellularity, oftentimes a lot of neutrophils. And it probably is in that same vein as a post-infectious GN that we see in humans, but those are uncommon. And we've seen it like, I mean, Friendship has a couple cases, I think, total. So there have been a lot, not a lot, but there are cases where we have IgA staining and lambda. So the lambda is being part of the IgA immunoglobulin, and it really has an activated complement. Those on histology are more often um, like mesangial hypercellularity and sometimes segmental sclerosis. Um, so just the presence of the IgA doesn't mean it's driving a really fulminant glomerulonephritis. Um, but it's also not seeming to activate complement, which is probably why it's not so hypercellular. Does that help? Is that trying to what you're getting at?
Yeah, I'm just curious at like the different, like why one would manifest more than another, and like how does that show up different histologically?
Yeah, and I think so. So for uh, anybody who uh, who has a little bit of crossover knowledge for human nephropathology, is that um, there is a disease entity which is anti-GBM disease. And so that is when the body makes antibodies against type 4 collagen, and it's the good Pasteur's epitope. And so in humans, when they have that type of pattern, that's not granular, it's linear. It's not making an actual immune complex that's getting deposited into the glomerulus. It's actually throwing antibodies that are then binding to the GBM. And so anti-GBM disease does not have this kind of dot, dot, dot. It is a strikingly linear uh, picture. Um, and then they're even better because it's not better, I should say, but the human nephropathology is even more advanced because you can also have diseases like lupus, which is basically you're making antibodies against a lot of different components in the body. And so you'll actually, what we call, have a full house pattern. And so you'll have all of the immunoglobulins being up, both kappa and lambda. You'll have evidence of C3 activation, and then you'll have activation of the classic complement pathway, which is a C1q antibody. We don't test for that in veterinary medicine. So that's a full house pattern. And you'll see staining of the glomeruli, but you'll also see staining of the tubules. And you'll see staining sometimes of the tubular-based membranes. Sometimes you'll see staining of the nuclei within the tubules. So it is so much better divided up in human nephropathology to say, okay, if I'm seeing staining where my GBM, my TBM, my nuclei are staining, and all of my immunoreactants on IF are positive, then I probably have lupus. And then you go back to the serology and realize the patient has lupus. But we basically only see this pattern. And now it might be just that our tests are not as sensitive as theirs and our IF antibodies aren't as good as theirs. But there's probably a lot more work to be done in this realm, and that's why it's a good discussion to have today in rounds, because it'd be great to have other antibodies that we could look for things for.
But also the thing to note, it really is if you go through the spectrum of human glomerular diseases and the ones that we see in dogs particularly, there's a larger menu of different diseases that occur and in some cases very commonly. For instance, IgA nephropathy in people worldwide is one of the most common ones. We can't say that it never occurs in dogs, but it's not anywhere near common. And the same with lupus nephritis. I don't know that we're diagnosed lupus, plain old, systemic lupus erythematosus in a dog is not something I have personally diagnosed, and I was highly confident of it. But even sometimes when I diagnosed that, the kidneys weren't involved, and then when I thought the kidneys were involved, it's a rare case. So we have a less diverse spectrum of immune-mediated glomerular disease that we're looking at, and therefore less diversity in the pattern of staining and the immune reactants that show up with staining than other people, than they see in people. And I apologize for the phone.
You apologize for the what? The phone?
Oh, the phone rang in the.
We didn't even hear it. So, okay. So I have a couple things on the chat, which I'll bring up in just a moment. But to show the electron microscopy, this is a montage. That's why we have a little bit of a darker image right here, just because of the way the EM scope put the images together. But I'm going to outline the capillary loop. So this is our GBM right here. And remember, when we looked at the PAS, and this is going to answer the PS versus a Jones question that's in the chat, the capillary walls were not strikingly thick or strikingly remodeled. This was a very hypercellular glomerulus, but not necessarily over striking remodeling of the GBM. But our electron deposits are both within the subepithelial regions here. Here's a little subendothelial deposit. And so we have deposits in multiple different locations. We have already thickened capillary walls with some, we have expansion because we have a little bit of mesangial interpositioning right at the base, kind of growing up into the capillary wall. But the actual lumen is right here, and here's probably an endothelial cell out there. So the PAS is helpful, more helpful than the Jones with response to this question on the chat, because it might show you the GBM remodeling. The Jones should. The PAS might show it to you, but it's also going to show you things like hyalinosis, and it's going to be able to show you things like staining properties with sclerosis that are going to differentiate a sclerosis case from an amyloid case. So hyalinosis is going to be bright pink, sclerosis is going to be pretty pink, amyloid should be pale pink. So the differential staining from the PAS is going to be helpful for that because it's going to tell you when there's expansion of the mesangium or capillary walls, it's probably sclerosis or it's probably hyalinosis. And then also just being able to outline where the capillary wall is will separate it from the podocyte cytoplasm. So you can see, okay, the podocyte cytoplasm's here, that podocyte's hypertrophied, and here's my GBM. And whereas an H&E will just put everything together as the same pink color. And yes, Haley is the expert of lupus, lupus-like lesions in lupus dogs, or in that breed. Okay, so the interesting thing is the deposits in this case are more commonly subepithelial, so they're beneath the podocytes, as opposed to being as frequently subendothelial. They're in both locations, which is what we see in a mixed pattern. So here we have some deposits out on that surface. We have a few deposits here that are within the other side of the GBM on the opposite side, kind of along where we think probably mesangial zones are. So the deposits in our particular dog have multiple different locations: subepithelial, frequent, subendothelial there, and mesangial as well. And that fits with the IF showing that we saw outlining of the capillary walls and then also within the mesangium as well. The podocytes are pretty affected. There's a lot of foot process effacement, a lot of microvillus transformation. So the podocytes are injured, and that's probably contributing somewhat to our proteinuria. And so the diagnosis was a mixed immune complex GN, and I think we said membranoproliferative pattern, and I think, let me look back quickly at the description. We had 12 gloms, none were globally sclerotic. There was let's see, segmental sclerosis is not a feature, so we didn't have actual definitive sclerosis at the time of the original biopsy procedure. Okay, so then we have all the information from Dr. Skinner, about how the various, I'll stop sharing. Do you want to pull that back up again about the treatments?
Yeah, let me figure out where I put it real quick. Gosh.
So this dog was put on immunosuppressive therapy. She's had multiple follow-up SDS pages, and I'm actually not sure that the original SDS page has been reported that was submitted at the same time as this biopsy, because it's still in the to be pending.
I did eventually get it. I think I had to
okay.
ask for it because it never got
Okay.
sent. Oh gosh. There we go. Okay. So there's Millie's actually been surprisingly stable from an azotemia perspective up until recently, which I think also fits with the lack of sclerosis. But there's her many medications.
Are you sharing? I don't think I'm seeing it.
Oh, I'm not sharing it yet. Okay, sorry. Can you see that now?
Yep.
There we go. All right.
Okay, so basically from the time of biopsy, and I'm assuming that middle column is the UPC at the time?
Yeah.
Okay, so from the time of biopsy, she's received multiple different types of immunosuppressive treatment therapies. And as Steph was alluding to earlier, really honestly, there's not been a lot of improvement. It does look like she kind of got a little bit better in May, and now she's kind of back to the 1s and the 3s, the 5s. And that's with the cyclophosphamide. How much cyclophosphamide has she eventually gotten? A lot?
She's been on cyclophosphamide for 9 months.
Okay.
We started her, this was after much discussion with Onc on like actual dosing regimes, but we started her on the Q3 weeks. And then I switched her, I think I switched her in March. So the meds are what she was on like at the time of that biopsy, not
Yeah.
what she was switched to. So
Switched to,
like
right.
in March, her UPC was really not that much significantly better, which is why I switched her to the daily dosing. And then she also, I felt pretty good that she was receiving her cyclophosphamide because she was pretty persistently significantly, or I guess like borderline neutropenic, which had never been a problem for her before. This was her pre-starting cyclophosphamide CBC. So it seemed like it was doing something, just not what I wanted it to do.
What was her lymphocyte count was also, were you keeping track of that?
I think it was
I mean,
yes,
obviously we're keeping track, but it's just
yeah.
not on the table. Yeah.
Yeah.
Okay. But was it staying?
I think it was static the entire time, and her platelets never dropped, which is what oncologists were a little bit worried about monitoring. They were worried about that 125. But then at the 293 is on that same dose of cyclophosphamide, she was on at 125.
Okay. So in kind of discussion with this, Dr. Foster had messaged the American Society of Nephrology boards, so the MDs, and just mentioned, and he's posted on there every so often, and so they know, they're aware that that sometimes we biopsy dogs. And I think he'd uploaded the report, or he just put the results of the report in the message. And one of the MDs, who is very well known, Dr. Classic, he looked at it and was like, well, we have positive lambda, we have positive IgG, we've got a hypercellular proliferative pattern. And so his comment was, well, this fits with a proliferative glomerulonephritis and monoclonal immune deposits, which is an actual diagnosis. It does have its own ICD-10 code, ICD-11 code, what code over we're at now. But it is a proliferative glomerular injury. You're going to see a lot of hypercellularity. There will be immune deposits, so you'll see electron densities in the EM. And then on immunofluorescence, you'll see a light chain restricted immunoglobulin, which is almost always IgG. And so whereas other types of immune complex disease, like let's say ones that are associated with infection or maybe lupus or whatever, they'll have staining for both kappa and lambda light chain. So, and they should be about similar in intensity. So this is again one of these subtypes of diseases that humans have, where the histology and the electron microscopy are very similar to just run-of-the-mill immune complex disease. But then once the IF is assessed and you see that it's either a lambda light chain IgG or a kappa light chain IgG, and then they often will do subtypes as well to see, because there's 4 versions of IgG. And so they'll see which version it is. And so that is a different, I don't know how to say it. It is a well-established diagnosis in human medicine, but the reason that we don't make that diagnosis is that in dogs and our experiences, all immune complex disease stands for lambda and not for kappa. And I know Dr. Moore is on here. I saw him earlier. Hopefully he was still here. He might have had to leave. Oh no, he's there. He is our person that we've been pinging with questions a lot recently about light chains and their formation and their association with immunoglobulins. And so I was hoping that he was able to join, which he is, to kind of at least give us more information about, is it that we just don't see kappa staining of our immunoglobulins because our antibody's so bad? Is it because dogs just don't make as many kappa light chains as they make lambda light chains, which has some backing in the literature that dogs make more lambda than they make kappa? And in humans, I'm right in saying that humans are, it's been so long since I've been practicing human nephropathology, but it's like 2/3 kappa, 1/3 lambda. Like the variation of light chains even in humans is not equal, correct?
Correct. It is not equal in
Okay.
humans, but it's closer to equal than what the limited data that we can come up with in the dog,
Okay.
at least the limited data that I trust in the dog comes through, right?
Right.
So to kind of get to your question, you asked about the antibodies themselves, and what we know from a couple of different studies is that using anti-human antibodies in dogs does not always accurately capture the light chain class.
Right.
The anti-human lambda will label lambda and it will label kappa. The anti-human kappa will label kappa and it will label lambda. And so some of that earlier data that we had that said, hey, we've got like a 1 kappa to 9 lambda ratio in the dog based on antibody may or may not be accurate.
Okay.
That being said, there's been some work with mass spec analysis that's suggested that it might actually be closer to 1 to 9. And that's not really well set just yet. And so I think we can say it's a little bit odd. The other oddity that is in this mix that I haven't been able to really well rationalize is that in neoplastic cases, the evidence is pretty good that there is overusage of kappa light chain in immunoglobulin producing neoplasms. If we're saying it's naturally at a 1 to 9 ratio.
Okay.
Right?
So then the kappa might creep up, but it's still not going to be like overwhelmingly more. I mean, it'll be more than expected, but not necessarily the dominant.
So in those kappa secreting tumors, it is the dominant light chain
okay.
being expressed. The ratio of kappa secreting tumors to lambda secreting tumors is closer to like 1 to 1, which doesn't make sense if you say your baseline plasma cells are 1 kappa to 9 lambda plasma cell in health. And
That
so
makes okay.
there's that weirdness, and we've not been able to well characterize that in markedly inflammatory cases. We've only been able to do that in a couple of them. And so there's a question as to what happens with inflammation as far as light chain usage.
Okay. So, and to give everybody some background on this, so the kidney biopsy service was established by Dr. Lees in 2005. 2006 was your first set of cases that came through Dr. Lees, right? 2005. And so it's been going for almost 20 years.
Yes.
Okay. So
First case, March 2005.
oh wow, we should have celebrated. Why did we not have a party? We should have had it when a party. Well, maybe we'll do it
You
when the
missed
service
the
is old enough.
invitation, I guess.
Maybe we'll do it when the service turns 21 and is old enough to have a beer with us. Okay, so and at the time, just starting to learn how to do immunofluorescence on a routine basis and do it obviously a lot people have done immunofluorescence in veterinary medicine, but it's always been like, hey, we're doing a case cohort and we're going to stain all these slides together, and we're not going to offer it as a routine diagnostic staple that would be done weekly, with hundreds, and now we're at thousands of examples. And so we would always stain for using an antibody, a fluorescent antibody against lambda light chain and against kappa light chain. We order them from DACO. They are against human lambda light chain and human kappa light chain. It is the same antibody that we would use at UNC as well. So it was the same kind of thing. And we were like, does it even work? And miraculously, it did seem to work. At least the lambda. The lambda seemed to show beautifully, so that every time we had immune deposits on electron microscopy, so we have that second piece of information of there's immune complexes here because we have electron dense deposits, we're going to see lambda positivity. And so but we hardly, if anything, ever saw kappa. I mean, I think if you go back in the records, there really honestly might be like a dusting or a small amount of speckling, but not necessarily the same gorgeous picture that I showed you for lambda. And so then as I was transitioning, I was working at UNC, then all of the different algorithms of, oh, this is why you do kappa and lambda, so you can compare the two. And when one is dominant, then you think, oh, it might be this proliferative glomerulonephritis and monoclonal immune deposits. And so, and that's when we kind of started paying attention. Well, kappa was never very strong. And so to the point where there was one case I distinctly remember, because I was still at UNC at the time, where kappa was very strong and lambda was very light. And I was like, well, this is very strange. And so we went back and we repeated everything, and the samples had been switched. So it really truly was still lambda strong and kappa weak. And so in a kind of a way to save effort and not have to do all the stains, we decided to stop performing the kappa light chain stain, but we still have 7 years of cases with the kappa stain in our archives. And we also used to try to do the C1Q. That's the other one that they do in human medicine, and it shows activation of the classical pathway of complement. We would occasionally get a positive, but it was very uncommon for us to see any positivity associated with it. And we really weren't sure what it would actually tell us. So we stopped that stain as well, because it basically could save us like $100 each biopsy. If we stop both of those stains. So we haven't been testing for it. We don't know, and we never tried to look for a different IF antibody out there for kappa. We just felt confident that the lambda would tell us that there was a good staining profile and a good staining pattern. And we didn't really venture out to try to find better or more optimal kappa light chain stains. So we've never looked at it. And so kind of posting that to the ASN website, having the MDs see that it was only kappa positive, or sorry, only lambda positive for Millie, but not realizing, well, we don't even test for kappa. That's probably part of it. That's why it was only positive. That's kind of one one kind of facet that I thought was interesting about this case, is that they immediately went down, if it's a human, it's obviously got to be this. And so that was their immediate recommendation. And then they also kind of are still surprised to this day that we don't have an anti-CD20 therapy available for easy usage in dogs and cats. And so because, being able to kill and specifically kill the B cells could be very helpful for this case. And that was kind of my question to Dr. Skinner, was that, yeah, that you're having some degree of immunosuppression because you have a neutropenia, but what are the lymphocytes actually doing in this case? Are they just not responding to the mycophenolate and to the Cytoxan? Like, are they not being killed? And so that's kind of the next kind of facet of this case. And I guess, Dr. Skinner, what's your opinion? Are they just staying in the marrow?
I was just gonna see if I could find, so her lymphocyte, she was lymphopenic at her last visit.
Okay.
She had 0.7 lymphs. Unfortunately, because a lot of the labs are done with the RDBM, they're not all lined up nicely
Right.
until I put them into a graph. But she was neutropenic, lymphopenic. Total white cells were 4. So I don't know what's going on with her. I am worried that she's not well controlled because she's losing weight, and that I don't know exactly what the connection with her GI and kidney diseases. I know we had like a run of Frenchies that all had GI changes and were proteinuric, but we historically haven't gotten GI biopsies. We've just treated them with like low fat hydrolyzed diets, and then we're immunosuppressing them for the immune complex GN. So, because I thought I know we were like, is there like an IgA situation going on here? And that's the GI component to this. So I think I might talk to the owners about rebiopsying as well. It's like some of what has driven her management is that she continues to have the very high molecular weight bands on her SDS page that they haven't changed. And that's also part of the concern that she's not well controlled.
So her SDS pages are still saying, sorry.
I was just going to ask, what has been done besides immunosuppressive for her GI disease? Since I know that there's, at least in people, a better understood connection as far as like kidney gut access and membranoproliferative GN with certain IBD subsets have been well recognized. And so I honestly thought like that's kind of where this was going. When this all started with looking at her original blood work, it looks like her GI disease and her weights, seem like she has pretty profound GI disease. So, and is there a connection between when her UPCs are ridiculous, like when she had a UPC of 21, how was her does there seem to be any connection between how she's doing from a GI disease perspective and what she's doing from a GN perspective?
Yeah, and it's a little bit hard for her because aside from she had vomiting and she had diarrhea when we were first working her up, but her only other symptom since then was weight loss or like the resolution of weight loss. She's not had any other GI signs beyond that.
Has she had a repeat abdominal ultrasound to show that the lymphangiectasia is still there, or?
Absolutely not.
Okay.
I focus her every time she comes in. The fusion's gone, but I won't make any comments on the presence or lack thereof of lymphangiectasia.
Okay. Yeah, I mean, this is just it is there are multiple facets to this case to the point as Jenna's even talking about of like we kind of have been lumping them in and together to be like, oh, there's at least deposits and we know there's immunoglobulin based deposits in here. But there are going to be subsets, right? There's going to be subsets which are multisystemic inflammatory disease that hit the GI and the GI disease and the kidney at the same time. And so we have a comment about monitoring total IgG, IgM, and IgA levels while on the cyclophosphamide to document the response. So that would be, and that was something I talked about Dr. Morris about sending off for protein electrophoresis for this case. However, I guess you would say for future, because at this point she's been on it since March, right?
Yeah, I mean, and in fairness, monitoring decreased levels by protein electrophoresis is a challenging beast, right?
Got it.
Because of the limitations of where that assay ended up running. And so running like an RID, a radial immunodiffusion or an ELISA assay is better choice for
Okay.
monitoring a decrease. But yes, we would need to document a baseline prior to treatment and then afterwards. We've got reference intervals for healthy dogs, but they're kind of wide and they're kind of loose. So I don't know how selective that would be, but like if you were to run those now and say, hey, everything's really low, you could at least document that, yeah, you're having an effect on immunoglobulin production, but that's total. It's not the targeted ones, right? So if
Right.
we have something, a specific plasma cell line that's just not responding well to the cyclophosphamide, and that's what's causing it's challenging that way.
Yeah. And it is all those things where it would be, as we were talking about in human medicine. So oftentimes they'll start with an anti-B cell therapy, but then sometimes they'll have to add in an anti-plasma cell therapy. And so JD was talking about bortezomib for this dog, to maybe see, because is it more getting rid of the plasma cells, is that can help us? But the other frustrating thing that is even in humans is we don't always know where the clone lives, right? So if it is a clonal population, and especially for the proliferative glomerulonephritis and monoclonal immune deposits, if there is truly a clone that's making this, and this isn't a response to an inflammatory thing where it's biclonal or limited clonality, but there's really one single clone, we don't know where that clone exists. It could be in a lymph node, it could be in the spleen, it could be in the marrow, and they also recommended on the ASN listserv for JD to recommend bone marrowing the dog. Again, they can just do whatever they want. I think this at least brings up to the forefront of how many things that yes, the biopsy service is now 20 years old, going on 21. But there's still so much out there that could be better characterized so that we could start pigeonholing these guys to be like, okay, you have multisystemic disease that seems to be immune complexes or immune system mediated, and then you would have your own set of therapy versus the ones that have an infectious disease that is basically causing overwhelming immune response that then is accidentally getting deposited in the glomerulus, then you have your other types of therapies. Because, and I am correct in that saying, Steph, this one never had any kind of infectious disease serology positivities, right?
No, we don't do a ton of testing here for it because we don't see a lot of it in the DC area, but I think you say like a -40X and I call that good.
Yeah.
Can I ask, you didn't do the infectious disease testing. Has it ever had electrophoresis or anything looking for a very low concentration monoclonal anything? Like, is there any evidence of a clonality in this patient?
Not that I have gone looking for.
Okay, PAR or IF would be the two that I'd reach for. I don't think it's there, but it'd be interesting to know.
And I guess I don't know if like the fact that this has been going on for a year and a half like changes the concern for that, because she has just been alive for so long.
So like the few MGUS patients that we can see and monitor over time in dogs, they creep along for years and years and years. There's still a clonal component there, right? A monoclonal gammopathy is present, but it's not broken into fulminant multiple myeloma.
Yeah, and I just put that MGUS is monoclonal gammopathy of unknown significance, and then eventually, if you start, so you could in humans, they identify people that have the clone or have the monoclonal spike, and they might have no clinical signs at all. It was just identified on blood work, and they'll follow them in humans for years and years, and then eventually, maybe the kidney will start to show mild proteinuria, and so then it goes from an MGUS to an MGERS, which is a monoclonal gammopathy of renal significance. I'm sure there's other organs that would be, because I'm only a kidney person, is there like an some other an MGOS, like ocular significance or something? But anyway, again, they smolder, and then eventually the fact that there's so much of that monoclonal chain being filtered out is gonna eventually damage the kidney. So yeah, I hope that and Dr. Skinner, I can put you in touch with Dr. Moore's. He's CSU. He's at CSU, so I'm sure you guys know how to submit stuff to them. But that way, that I mean, because maybe this is something we would just want to do as a small case series. Like, let's follow immunoglobulin levels on patients that we're putting on our immunosuppressive therapies. There's not even in the onco literature stuff like that, right, Dr. Moore?
I've not come across it, no.
Okay.
No, I really haven't. I mean, there's the M protein monitoring, but we're targeting a plasma cell tumor.
Right.
Here we're looking at, in a lymphoma patient, have we looked at the non-involved immunoglobulins? In an inflammatory, have we looked at, where we're immunosuppressing? That, I think that would be an interesting piece to look at.
Yeah. And it would even, I mean, just knowing how often these guys are reaching for immunosuppression would be a good cohort to start to collect samples for. So
yep. Let me chime in with a 20-year-old comment or perspective, comment on a 20-year-old perspective. It's always seemed to me that we, in our efforts to define dog particularly, but also others, cats and whatnot, kidney diseases, that we were very limited compared with human medicine. And I went to all their meetings and sat in all their courses and whatnot, with the number of tools in their toolbox compared to the tools in our toolbox. Not just tools about staining or otherwise probing renal tissue, but serologic testing. I mean, I'd sit in on renal rounds and they'd present the case, and there were, you know, anywhere from 5 to a dozen serologic tests that they'd already run to rule in or rule out different things and whatnot. And then the next thing is that any effort to expand our toolbox is has been to ask whether human reagents cross-react reliably with dog substrates, whether it be tissue or serological. And so the challenge, and I'll acknowledge right to begin with, if it was easy, I'd have started on it 20 years ago. But I only do easy things. So the challenge may be for the nephropathology and veterinary medicine initiative, you know, to really make some changes is to have an R&D component to what we're trying to do, that not just takes what we already know and do it over and over again with the tools that we already have, but to find people who have the interest and skill set and background to, you know, make new antibodies specifically for, you know, use in dog. And now with the molecular genetics, molecular biology, and the ability, I mean, the technological armamentarium that's out there to do that I don't even understand, but it must be way beyond what it was 20 years ago. It may be that and you can't do everything all the time, so you got to pick some low-hanging fruit and get started. But that we should be maybe finding some way to target inventing stuff for our use that will help us.
Yeah, I agree. I agree with that. And I mean, even when we were just kind of discussing, like, oh, it'd be nice to find whether or not we could get a Kappa stain working. I mean, we're at this point, we're doing our best to try. We would love to have a diagnostic test to give us C3 levels and C4 levels in the blood, so that we could track serologic values of that, because it should decrease as they're having a flare. So anyway, there's a lot of things that we have on our wish list. And for anybody out there who is wanting to be in nephropathology, or excuse me, nephrology in general, if you ever want a project, obviously we have a lot to throw your way. So it is 1 minute past the hour, so I'm going to sign off. We should be having rounds again next month. I know this was a limited population because ECVIM is happening right now. And so a lot of people are in Europe enjoying Europe. But we will reconvene in October and I'm going to make sure Dr. Skinner and Dr. Moore that I can give you guys contact information. And then hopefully maybe we could even just get some baseline levels, or not baseline levels, but levels at this point for her immunoglobulin values. Okay. Thank you guys. I appreciate it.
One last thing.
Oh,
well, with these kind of cases, that you have people pulling out their hair. One thing we used to do at Minnesota all the time was save serum as we went along, so that we could go back and do tests in retrospect that we had no idea that we wanted, much less, and sometimes even couldn't do until later, but had the serum bank for that purpose. So it can be a relatively easy habit to adopt if you get the infrastructure in place.
Yeah, we will look. And I know, Steph, that I know you guys have been submitting urines for this whole time, but I'm not sure if you were submitting serum at the same time to Jess.
I think we usually do.
Okay,
Usually the
well,
text.
we might have some frozen at the IVRPS then. Okay. Okay.
Hooray.
I will look. Thanks, guys. Have a good month. See you soon.